Potentially. I think it's really important to dig in and investigate a little bit more about actually what is happening. So we automatically attribute to women who are having urinary incontinence is, oh, it must be stress incontinence or urge. We forget that women can also have an incomplete bladder emptying and that that's an overflow that can lead to that. So I think really digging in a little bit deeper and asking more specific questions that are related to that overflow, which is there hesitancy? Do you have dribbling? Do you feel like you're not emptying out your bladder all the way? Do you have a weak urinary stream? And then measuring for that post-void residual. Most GYN offices are going to have an ultrasound machine, and you don't have to have a specialized PVR machine where it's just this little ultrasound to go over the suprapubic area to measure that. So an easy thing to do is just measure that post-void residual. But again, I don't think a lot of GYNs have learned that through their training. So that can be another great addition thing that you can do. And if you're finding that you're checking those boxes of they're not emptying, some hesitancy, and you're getting kind of that post-void residual much higher, I would potentially say we probably should investigate an endocrine thyroid issue and then drawing some labs. So again, that's just something to think about. And then it's the chicken or the egg. So we know from some retrospective studies looking at women with hypothyroidism, when they have been asked about their urinary symptoms, a big portion of them also have stress and urge or mixed incontinence. So there is potentially some correlation with hypothyroidism contributing to those other types of urinary incontinence. Pretty much new onset urinary incontinence is where that flag should peak up and ask a few more questions that may be suggestive of a hypothyroid situation. For instance, asking about temperature. We think about temperature and asking our patients in perimenopause or menopause, they're hot, right? They're like temperatures. And so if they say, I've been really cold lately, I feel like I have some cold intolerance, it's another like red flag to like peak up your interest. So thinking about that, thinking about constipation, if they've noticed new onset constipation, right? Everything's slowing. If they've noticed a lot of just fatigue, maybe they're not sleeping as well, or maybe they're sleeping really well, but they just don't feel rested. That could also be some sleep apnea. We know women are not screened as much for sleep apnea also. But thinking about skin, hair, nail changes that could be going on, hair loss in particular, and then thinning of that skin. And then also asking about any kind of history of thyroid disease or even autoimmune concerns too. We know that women have more autoimmune conditions. So don't forget to ask about those. That history can be really helpful in narrowing in if this is a thyroid issue. And again, thinking about just those overflow and more incomplete bladder emptying screening questions is going to lead you more into that also. And then thinking about, is this correlated with a life change? So we know postpartum, you can definitely see some changes in thyroid as we transition in perimenopause and menopause. And some of those symptoms are overlapping. And we know the Menopause Society strongly encourages practitioners to check for thyroid concerns also before you get them started on hormone therapy. So this is a great way to just use a comprehensive, holistic approach to what's going on with that patient. Data. I'm a data girl. I love to have the numbers. I can geek out on it all day. So having like a bladder diary, and most of your patients are going to be really excited to look at that data as well. You can download apps, you can print things off, you can get PDFs. So the access to those is really highly available to your patients. Making sure that they have some sort of measurement tool at home. So this could be a hat that they could put in a toilet. I would say probably a good portion of GYN specialists will have that, but most of the time you're going to have a urologist just down the road or at a same hospital system that you could just, ask for one of those products as well. So that can be really helpful just to get some data. I'm a big fan of timed voiding too. When we're thinking about hypothyroid, again, everything is slowing down. So people may not go to the bathroom as frequently or feel the urge to go. So ensuring that they're trying to go to the bathroom every 2, maybe 3 hours. Urge suppression strategies too, especially if they were like, I just went to the bathroom and now I feel like I got to go again. You can do some small pelvic floor muscle contractions to be able to help with that, or doing some diaphragmatic breathing to get over that hump, to get over that bladder spasm, that urgency feeling. Fluid timing can be another one. So again, making sure that you are front loading your day with fluid intake, lots of water. You could do electrolytes in the water, and then limiting that fluid intake at night so that folks aren't getting up as much during nighttime too. Constipation management is always one. So lots of fiber, movement is going to be really helpful. And then consider pelvic floor therapy. There can be a lot of coordination dysfunction that happens between the bladder and the pelvic floor for people who have a history of hypothyroidism. So being able to have a pelvic floor therapist to help support you and to recognize those cues, give you some biofeedback can be really helpful. There can be some tools also. We recognize that while pelvic floor therapy is great, it's going to take some time. So again, setting up those realistic expectations that it could take 8 to 12 weeks for people to see some improvement. But what do people do in the interim? This is where you can reach out to people, organizations like Aeroflow Urology, where you can get some incontinence products to help support those folks along the way. So oftentimes I hear, well, I don't know what to do, or these products are really expensive. But Aeroflow Urology is great with working with people's insurances to get the insurance to cover those. Skin, barrier techniques and products can be really helpful. We're talking about potentially some pelvic organ prolapse, so a pessary can be another great thing while we're kind of in the interim. And then all of this is just very much having a dynamic conversation with the patient with shared decision making. And again, I think that's education is so important. And when patients feel that they are a part of the conversation and not the center of the conversation, they are more apt to be a part of the care and the action plan. And so when they know that there's a goal or we're working towards something, they are much more apt to be patient. I tell all my patients I don't have a magic wand. I wish I really did, and I could just wave it over top of you and we just move on and be done with it. But it's time. And especially if you are starting a thyroid medication, we know that sometimes with endocrine systems, it can take 8 to 12 weeks for things to balance out. So, and once things are more balanced and you have more harmony in those endocrine functions, your bladder and your pelvis will follow suit.